Okay, so today we're going to be talking about some hematologic disorders. So the one thing we're going to look at normal and abnormal assessment findings. We're going to be looking at those diagnostic results and diagnostic studies. So the first thing we want to look at is our red blood cell count. Oops. So the first thing we want to look at is the CBC, looking at the leukocytes. So looking at the leukocytes, those are our white blood cells. The other thing we want to look at is that differential. The differential is going to give us a lot of information. When we look at the differential, we're going to be looking at the neutrophils. Neutrophils are our white blood cells that are bacterial fighters. These are about 50 to 70% in a normal person. We're going to be looking at the differential of the neutrophils also, looking at those segmented neutrophils, which are our soldiers against the infection. And then we can also see our bands, which are going to be our immature or our cadets. So when we're looking at the neutrophils, if we see somebody that has a lower than normal segmented and a higher bands, that means that they've been fighting that infection for a while. Or it's an overwhelming infection because now our bone marrow is kicking out all those immature cells. The eosinophils are going to be our allergic. These are where our mast cells come from. We also can see basophils have some allergic response. They're also good for seeing if we have a parasitic infection. You guys are going to be talking about kids, and one of the things that kids get is Giardia lamblia, which is an amoeba infection. And so on those kids, their white blood cell count may be normal or just a little bit high, but we're going to be looking at those basos to see, is this amoebic? Lymphocytes are our virus fighters, so we're going to be looking at those. Again, we may see a white blood cell count that's normal or a little bit elevated. Neutrophils are going to be normal, but if it's a viral infection, we're not going to see, we're going to see a high lymphocyte. The other thing I wanted to point out, well, let me tell you about the monocytes too. The monocytes are our chronic infection fighters. Those are our macrophages. And those are the guys that we're going to see for those patients that have had that diabetic foot ulcer that just won't heal. The other thing I wanted to point out is if you notice, these are all percentages. These are all percentages of the white blood cell count. So if I have a really high lymphocyte count, let's say my lymphocyte is 60%, one of these other guys is going to be lower because it's a percentage of the total number. So looking at it, I want to see, if I see 50% of the lymphocytes, I might see a neutrophil count down to 40 or 30. It doesn't mean that my patient has that my patient has a bacterial infection or maybe they have a neutrophilia. It's because I have a really high lymphocyte count. So it all equals 100% or close to it. We also know that the hemoglobin and hematocrit can tell us about our patient's hydration status. So if we have a really high hematocrit, we're going to see a hemo concentration. We're going to see a patient who is dehydrated. Again, if we have a really low hematocrit, that's going to show us a patient that is overhydrated. Normal should be, your hematocrit should be about 3 times what the hemoglobin is. So you can see here that it shows that the hemoglobin is 12 and the hematocrit is 36%. That's pretty close. When we look at the CBC also, we want to look at the red blood cell count. So we're going to be looking at our hemoglobin and hematocrit. We know that the normals are different from men and women. We know that if we're concentrated or diluted, those are going to be changed too. The other thing we're going to be looking at is RBC indices. Looking at the MCV, or the mean corpuscle volume. This is the size of the red blood cells. A low MCV tells us that we have a microcytosis. We have I always think of them as a low skinny, the 90-pound weakling. They're microcytic. And then if we have a really high MCV, they're going to be macrocytic. They're going to be that big, buff red blood cell. The other thing we're going to be looking at is the MCH, the mean corpuscle hemoglobin. And this is the average weight of our red blood cell. A low MCH, we're going to see microcytosis or hypochromia, really pale looking white red blood cells. We might see a high MCH. This is macrocytosis again. We're going to be looking, when we talk about macrocytosis, macrocytosis is your megaloblastic anemias. These are your, I just lost my place. Vitamin B12 or folate deficiency. Our microcytic are iron deficiency anemias. We're also we may also see hypochromia in our MCH. Hypochromia is that pale looking. Again, looking at the MCH. The MCHC is the red blood cell saturation with hemoglobin. That is the mean corpuscle hemoglobin concentration. So a low MCHC again is hypochromia, a high is spherocytosis. Then we're also going to be looking at the RBC morphology, looking at the size and shape. They all should be uniform. We may see red blood cells that are rollio, which is French for in a roll, and that's an indicator of an infection. We also may see larger or smaller in the same smear. The other thing we want to look at is the reticulocyte count. Reticulocytes are the immature red blood cells. So kind of like our bands in the white blood cells, we're going to see retics in the red blood cells. And then the last thing we want to look at is our platelets. So when we talk about sickle cell anemia, which will be coming up shortly, we're looking at a normal hemoglobin that attaches, a normal hemoglobin can attach 4 oxygen molecules to it. When we look at our sickle patients, the red blood cells look like a sickle. And so the oxygen can't attach to the red blood cell. So that's really significant when we look at our patients with sickle cell anemia, because hypoxia causes it and the patients become very hypoxic. Some other diagnostics tests are part of our CBC. We want to look at the platelets. We know that 150 to 400,000 is normal, and we want to be looking at make sure our patient is normal. If the platelets are low, they're going to have a bleeding problem. If the platelets are high, they're going to have DVTs. They're going to have a lot of clotting problems. The other thing we want to look at is the PTT and the PT-INR. We saw this when we looked at our patients that had liver disease. We know that the part of the clotting cascade and those uh, proteins come from the liver. So not only can we see liver problems with our patients that have really high PTTs and PTINRs, we also can see it with our patients that are on medications. So again, I'm a really big fan of memory notebooks. So looking at Coumadin, the PT, or warfarin, the PT boats in World War II, and my favorite that I always remember is heparin. If you use the H, it equals a TT, and that's how you remember heparin. Heparin is associated with the PTT, and warfarin is associated with the PT. Some other diagnostic tests that we want to look at is our serum iron. Again, we're going to be looking at iron deficiency anemia. This is going to evaluate the iron metabolism. So this is the amount of iron combined with proteins in the serum. We also can look at the ferritin. The ferritin is a major iron storage protein. So when we look at the serum iron, we're going to be looking at the iron that's available in the blood tied to the ferritin. The TIBC provides measurement of all the proteins that can bind and transport iron. TIBC is the total iron binding capacity. So when we look at these alternative proteins that bind the iron, usually the transferrin is also one of the iron protein carriers. So when we look at ferritin and the transferrin and the TIBC, we're going to be looking at the availability of iron for erythropoiesis. And the transferrin saturation, looking at how saturated that protein is, and that tells us how much iron is available. We also can look at folic acid. This is the amount of folic acid that's available for RBC production. And then we can also look at the SED rate, the erythrocyte sedimentation rate. This is a marker for chronic inflammatory or chronic infections. And what it does is they put some blood in, and they watch to see how fast or slow the erythrocytes filter out of the filters out of the plasma. Okay, the last thing is the bone marrow biopsy. We know that our bone marrow produces 3 million red blood cells. We want to do a bone, if we have patients that have some irregularities, and we'll be talking about them, we'll be talking about multiple myeloma. And so we want to see what's going on in that bone marrow. The best way to do it is take it off the iliac crest. We can do it in kids and adults. Before we do it, we need to explain the procedure. We need to obtain consent. We want, maybe they'll do a local on this. Afterwards, they need to apply pressure because it will bleed. And need to be assessing your patient's vital signs. And if you have any questions, we'll talk about it in class.